afternoon and welcome to today's webinar, Managing Open Interdental Spaces with Indirect Veneer Restorations with Dr. Bob Winter. Before we get started today, I have just a few reminders for you. With so many people using virtual platforms, you may experience some lag in your feed. If this is the case, please wait a few moments. It will likely resolve itself. If it does not, please utilize the chat function at the bottom of your page, and we will do everything in our power to assist you in a resolution. We will have a Q&A section in this webinar. If you have any questions while viewing the lecture, please utilize the Q&A function at the bottom of your screen. It is now my pleasure to introduce to you Dr. Bob Winter.
Thank you for that introduction. I'm Bob Winter, a prosthodontist and master dental technician. My practice is in Southern California, Irvine, and adjacent to my dental practice is my dental laboratory, Aesthetics by Design. So over the almost 40 years now of clinical practice, I've done my laboratory work and have many dental technicians over the years. And so this particular topic I'm going to be addressing, managing open interdental space with indirect veneer restorations. It sounds maybe like a simple topic, but in fact, it creates many challenges for not only clinicians, but dental technicians. And the dental technicians are expected to solve many of these problems. In addition to my clinical practice and the laboratory, I'm full-time at Spear. I spend 90 days a year teaching workshops in Scottsdale, as well as producing online content and content for our study clubs. Okay, so the objectives for this webinar are to examine the reasons for open interdental spaces and their indirect restorative solutions. Many of the things I'll be discussing can be used for direct composites, for example, but with a veneer restoration, it complicates things because of the location of the finish line interdentally. So one of the keys is the preparation design for veneers. In addition to that, I'll discuss provisionalization and guiding and support of the papilla, and then to discuss communication to the dental technician to predictably close the spaces. So this brief example I'll run through, patient presents with veneers on her central incisors, desiring to make other aesthetic changes, but you can see that she probably had a diastema on these veneers. We're closing the space, and now with gingival changes, you can see a little black triangle. Radiographically, we'll talk about assessing root form and root approximation, and you start visualizing your preparation in order to help us close that interdental space. So ultimately, we prep the teeth, and what we have to think about is prepping the teeth with an outcome in mind. And that means we have to have a clear understanding where those finish lines need to be, both gingivally as well as interdentally. So the provisional restorations are designed to support and guide the soft tissue, in this case in particular, to see if we can get the papilla to creep a little bit more incisally. Impressions are taken, master casts are created, and then the dental technician manages these casts, manages the soft tissue to create space for the restorative materials. These are the details that we'll be walking into a little bit later. So finally, the veneers are fabricated on the stone cast, which is a fairly accurate representation of the clinical situation, but because of retraction of the tissue, it's not 100%. So there has to be a lot of thought that goes into the proper design to not only create the support of the soft tissue, but to create an individual look to the veneer restorations. So then at the time of try-in, our goal is to try in the restorations and at that time assess and evaluate the soft tissue so we have predictable outcomes. We want to avoid any changes or remakes in the situation. So we start off looking at natural teeth. And one of the things we have to initially consider is width to length proportions. And on the average, it's 75 to 85% width to length. And there's research to support those numbers. When you look at the height of the papilla, It's 40 to 50% of the height from gingival margin to the tip of the papilla, and the contact length will be 50 to 60% of the total length of the tooth from incisal edge to the, looking at the total length of the tooth to the free gingival margin, but here specifically looking at contact length. So it's easier to assess incisal edge to the gingival aspect of the contact. So let's say 50-50 or 40-60. So then we have to look at, again, natural teeth. We look at tooth shape. The tooth shape actually dictates the contact length and location. Here, these teeth are somewhat triangular shaped, smaller contact length. It's located in the incisal third. We have an open interdental space, but we have a papilla that's normal in height. Other examples, maybe even more severe examples, smaller contact lengths, more triangular shaped teeth. And you could say on the right-hand side, that papilla would be a super papilla, more than 50% of the overall length of the tooth, even though there has been some wear on the incisal edges. It's an incredibly tall papilla. The question might be is if you intervene with restorative materials such as veneers, as we'll be discussing, and I influence the tissue in a negative way, will that papilla be maintained or will it shrink up, and where do we position the contact? So looking at normal biology, and if we look at the definition of biologic width, it's the supracrustal tissue attachment. That is the new term that's going to be eliminating the term of biologic width. So supracrustal tissue attachment. Facially, we have 2 millimeters with a 1 millimeter average sulcus depth. Interproximally, it's also 2 millimeters on the average with a 2.5 millimeter sulcus depth. That means we have a 4.5 millimeter papilla height. If you look at Tarnow's work, he said if the interdental contact is 5 millimeters from bone, the soft tissue will fill in. If you look at Van der Velden's work, early 80s, in surgical healing and regeneration of tissue, even if you cut off all of the tissue, you get approximately 2 millimeters of attachment, and his research showed 2.3 millimeters of sulcus depth interdentally. So I think knowing the average biology and norm is really important. So you look at your radiographs and you look at the tooth form, you look at root alignment, and of course you assess periodontal health. And if we have an optimal situation, we have a bony scallop, and the soft tissue follows that bony scallop, and we have soft tissue filling in that space. A simple example, 2 restorations on central incisors. Patient wants to improve them aesthetically. They'll be removed. I remove them, cleaned up the preparations, and then fabricated 2 new restorations. Here, I'm not sure why the finish lines are prepped as deep as they were interdentally. Maybe it wasn't necessary. And so we'll talk about, we want to be the minimally invasive. So if I would see this patient today, and if I was prepping the teeth the first time, and I felt that I could manage the space between teeth easily, I would put the finish line maybe a ½ millimeter subgingivally, because I don't need to manage open interdental spaces. So here, another good example, I need to remove a single central crown, and there's a little chip on the adjacent central. Patient wants that restored, and I discussed with the patient options to close that space. And the patient said, I've always had that space. There's no need to close that space. So therefore, I left it. But when I made my new restoration that was properly contoured to mimic the adjacent tooth, in fact, that black triangle gets larger because it's not a 1-tooth problem. It's almost 100% of the time a 2-tooth problem. You have to manage 2 teeth. So in this case, the patient said she wanted this space. And of course, you test that out in provisionalization, because with the properly contoured provisional, they may say, no, on second thought, can you close that space? And then I might do a simple direct composite on the adjacent central and replace the crown. So normal root alignment with triangular or ovoid shaped teeth may create a black triangle. So looking at the radiographs, assessing, again, root form and position, contact, and you can see that with root form, you can have a more tapered root form, and that decreases the volume of space between the roots of the teeth, so supracrestally, and that may therefore allow a more blunted papilla, and that may create a black triangle. So root form is important. And then you look at the alignment of the roots. So diverging roots increases the volume of space, again, between the roots. And then that means that the soft tissue is not supported. So my simple statement is we need hard tissue, bone, roots of teeth, anatomic crowns, or restorative materials to support the soft tissue to decrease the volume of space, and therefore we can manage the soft tissue more ideally. So the question is mainly, is the sulcus depth normal or excessive? So if I see a really tall papilla as between these two centrals, and if I have a 2.5 millimeter normal sulcus depth, and if I need to manage this little space, I think I can manage that little space with direct composite, and it would be a very successful. But if I had, let's say, a 4 millimeter deep sulcus, and then I try and manage that tiny little space, and if I traumatize that soft tissue, it may shrink up more close to the norm of 2.5 millimeter sulcus. So this is where we have to think about how we're managing soft tissue. And if we traumatize it, the most aggressive way would be surgical procedures, or restorative procedures can aggravate the soft tissue. So will that soft tissue be maintained? In particular, will the papilla be maintained? And in this case, you could argue it would be better if that papilla between the central was moved apically to be more in harmony with the adjacent papilla heights. But the underlying key is looking at anatomic crown form, root approximation, where the bone is, and then knowing sulcus depth. So if we have periodontal disease and we have interproximal bone loss, that means we're losing hard structure support. The papilla may move apically. If it does, the gingival scallop flattens. You could just have a deeper sulcus depth, right? But if the tissue follows the bone, we have a flattened gingival scallop. And maybe this is a good example of this. Some restored teeth. And when I evaluated the patient, that papilla is now beginning to be a little blunted. You look at the radiograph, you can assess bone loss. You see root approximation is pretty normal. So it's really bone loss has occurred. And then you look at current papilla height. And if we had normal bone, you can imagine initially these restorations were made appropriately and the papilla filled in that space. So the hard structure that changes, the bone moved apically because of the periodontal disease. Another situation where there was periodontal disease, I didn't see the patient initially, but the patient was referred to me from a periodontist asking me to restore the one tooth, make a new crown for the patient. It's not a one tooth problem though. So certainly I can make a prettier porcelain, I can move the gingival level and hide that discolored root, but if the patient wants that possible black triangle closed, now we have a tooth form problem. We have a very triangular shaped tooth. The contact would be in the incisal third. So what I need to do with the new restoration is extend the material, in this case it was margin material on a porcelain fused to metal crown, interdentally to decrease the volume of space. I did composite bonding on the adjacent central, and I made a longer contact, and therefore now the papilla is filling in, creeping up, and as it continues to, I'll say, mature because of the volume of space has been decreased, I've eliminated the volume of space, but it is in essence a two-tooth problem. I have to change both teeth. And here again, history of periodontal disease. New restorations are fabricated on all the upper teeth. And you can see we have a flattened gingival scallop, so really long contacts. And of course, this is a patient that's on in years, an aged patient, and so it can work. Okay, so the larger the space between the teeth, the more blunt the papilla. So here now I'm showing you a diastema. So as I move the teeth apart, we're eliminating the support by teeth and roots. And another example where there were metal ceramic crowns on this patient, periodontal disease, which needs to be treated. I removed the old crowns before the periodontal procedures. After the periodontal procedures. So the periodontal procedures were done first. And now you can see between the centrals, we have a cratering. We no longer have a papilla. Then I remove the crowns and I prepare the teeth, and the tissue is now maturing. I use my provisionals to guide the tissue the best I could, but because the teeth were so far apart, in this case, probably 5 millimeters, there's little I can do for managing the papilla to creep incisally. So there's no question orthodontic treatment will be the best option in many cases, but I'm going to touch on that in a moment. But this focus of this program is really dealing with veneers and managing tissues. So trying in the restoration, and here you can see all 4 are tried in. You can see the papilla between the central is creeping up, or is it an illusion of that because of the depth of the, or the height of the papilla on the palatal area. But it's improvement, but certainly we can't solve all the problems with restorative means. Between the centrals and laterals, it's a normal situation, so it's easiest to manage. So if I have flat interproximal surface, in other words, proper tooth form and alignment, they're standing vertically, you can do bodily movement orthodontically to close the space. So there's no recontouring of the tooth that's required. So with orthodontic means, you can bring the teeth together and you solve the problem. So that's why orthodontics should always be one of your first considerations to help the patient overall, and maybe to simplify the restorative procedures. So this is the case that I'm going to show you predominantly in this webinar. Is a dentist that is desiring to change the form of his teeth. He has incisal wear, history of fractures and composites are on the incisal edge, class 4 on the central and a chip on the other central. He wants to close the spaces, and he doesn't like the form of his teeth, even though he wants to add length because of the incisal wear. We look at the diastemas are present, but he has triangular shaped teeth here. And so if I take a burr and plasty the interproximals and then do that on all of the anterior teeth and add the restorative length that he would like, then the question is, are the teeth too long and too narrow? So that's why I touched on a quick review of normal tooth proportion being 75 to 85% width to length proportion. So with a conceptual design, you can show the patient and ask, is that acceptable or not? If they say yes, it might be a straightforward orthodontic case with composite bonding on incisal edges. So in this situation, single central, it looks wider than the adjacent central. And what's interesting, when I remove the crown, you look at the adjacent central and you can see, again, the contact would darn near be at the incisal edge. And if I made an adjacent crown to mimic that form, there would be a long black triangle. So in fact, here again, rather than restoring the adjacent central by placing composite, if I can plasty the adjacent tooth, that would be my first choice, make a longer, flatter contact, then fabricate the new restoration. And fortunately, I was able to contour in a way that it measures the same width as the adjacent tooth. we have success, and I've actually restored one tooth, not two, but it was still a two-tooth problem. I manage it by plasty of the adjacent central. So I've made two flow charts looking at a black triangle is present with periodontal disease. And if you just look at this flow, I'll walk through this pretty efficiently. If I have interproximal horizontal bone loss, in the first is there'll be no bone loss. The second will be yes, there's bone loss. So we have periodontal disease, but no interproximal bone loss. There may be inflammation of the tissue, so I have increased probing depth, so I have to resolve that inflammation. And if a black triangle was present, it may become larger, but I still have a normal gingival scallop. So then the restoration margin would be placed half the depth of the sulcus. The gingival extent of the interdental placement of the finish line is going to be at the anticipated height of the papilla. So we'll be talking about how the papillas will be moving shortly. So now if I have interproximal bone loss, we have normal probing. That means the papilla moved apical to follow the bone loss. We have a flatter gingival scallop. In the same concept, the restoration margin placed half the depth of the sulcus. That is the key to everything I'll talk about, knowing sulcus depth and never prepping deeper than half the measured depth. And then the gingival extent of the interdental contact is placed at the anticipated papilla height. So now we have increased probing depth with interproximal bone loss. You have to resolve the inflammation, obviously treating the disease process. The black triangle typically gets larger, but you may also have a flatter gingival scallop, and then the same process occurs. But now if we look at a situation where there's no periodontal disease, so we have anatomic crown form is normal, root alignment is normal, sulcus depth is normal, then I restore subgingival and the contact is placed at the papilla tip. If the sulcus depth is shallow, then we have to think about we restore subgingivally, and now I have to position the contact at the anticipated height of the papilla. So the papilla is going to creep. We'll discuss again how we know that in a moment. If we have diverging roots, then you consider ortho and possible restorative. If we have the anatomic crown form of being triangular or ovoid, we can consider enamelplasty. I showed you that, ortho and possibly restorative. You start thinking about sulcus depth. If it's normal, restore subgingival, contact placed at the tip of the papilla. And if it's a shallow sulcus, restore subgingivally, contact position at the anticipated papilla height, right? That's going to creep. Question is how much? So our patient has diastemas. The most important area to evaluate this is not in the anatomic crown form near the incisal third. It will be at 1 millimeter subgingival, because as we go subgingival, the volume of space gets greater between the teeth, because in good example, on the right lateral, the root is more toward the distal. So as I go subgingival, we have, I'll say, broader bone, but the roots are farther apart. So that is actually the biggest problem area, is between the right lateral and the right central incisor. From an incisal view, you can see what we're going to deal with from wear perspective on the incisal edge. Okay, so black triangles. The papilla decreases in height with increasing interdental space caused by root angulation, as I was just showing you clinically, between the lateral and central. If I create a diastema, it's identically the same problem, but now I have to deal with the anatomic form, and I would argue in both cases. But if I have a diastema, the teeth may get physically wider, which may then negatively impact the width to length proportion. So interproximally, If I have a diastema, what do we have? The same 2 millimeter attachment, but the sulcus depth is less than 2.5, and I can't tell you what that'll be. It may be 2, it may be 1.5, it may be 1, it may be as the same on the facial aspect. And I always look at extremes. If I extracted the adjacent tooth and now I have an edentulous area, we are not going to have a 2.5 millimeter tall papilla. It needs to be supported by adjacent hard structure. So if we're missing that tooth, the sulcus depth goes to typically 1 millimeter, similar to that of the facial aspect. So the bigger the space, the more blunt the papilla. So here I'm giving a range of 3 to 4 millimeters, so less than 4.5. And the number I always use for the norm is 4.5, because I think that's based more on biology. So 3 millimeters might be the shortest, 2 millimeters attachment, 1 millimeter sulcus. So then the preparation finish line is placed half the depth of the sulcus. So knowing the initial sulcus, that's important. So when I see my patients and I know I'm prepping the teeth for veneers, after I give the local anesthetic, I re-probe gently, because you can penetrate the attachment with a periodontal probe. On the average, you penetrate it by 0.5 millimeter. So I gently probe and reconfirm my sulcus depths before I begin, because I never want to put, of course, position the preparation finish line in the attachment. Okay, so the convex restoration form is the essential part of the restorative phase. So here you're relying on the dental technician to make your veneers with the right shape. And where I'm going to go with this is, how do they know what is the right shape, and where do they need to position the gingival extent of the interdental contact? But in general, we want to provide a convex restorative shape, because if I then do that, I'm decreasing the volume of space, and that allows the papilla to creep incisally. It influences the papilla, so it's going to get close to the norm. And how do I test this out? Of course, it'll be in provisionals. So our patient, as he presents, he had a 2 millimeter sulcus depth. That means at best, if I'm considering norms or averages, I'm going to get a 0.5 millimeter movement of the incisal papilla. And I say possible. I already look at these papillas and I'm scratching my head. Yeah, they're flat. Yeah, if I squeeze that down with the right convex form, yeah, it might nudge up a little bit. I'm thinking maybe the maximum of 0.5 millimeter. So finish line located is 1 millimeter subgingival, so half the preparation depth, half the sulcus depth is where I position the interdental finish line. And then this is a photograph at the time of the tooth preparation. So when I prep the teeth away, the papilla blunts. We have to be conscious of that, because then you look at this and you say, well, my finish line isn't deep enough subgingival, but just keep in mind that as you remove hard structure, the tissue is going to change. The margin was initially placed 1 millimeter subgingival, and I expect 0.5 millimeter of incisal movement of that papilla. So that means I must make the interdental contact 1.5 millimeters from the interproximal finish line. That's the information the technician is going to need to know during the fabrication of the restorations. That's what I need to know when I fabricate my provisional restorations. So here, clinically, the desired convex restorative form. If I do not prep deep enough into the sulcus, in other words, I prep to the height of the papilla, I wind up with this horizontal ledge, and therefore I am not managing the tissue. I'm covering over the top of the tissue. That's why we need to be subgingival. And here's maybe a good example of what I'm trying to avoid. Not my case, but was able to get casts from the original situation. The clinician fabricated veneers, and now there's horizontal ledges resting on top of the papilla. So at the time of the preparations, the soft tissue blunts or flattens out. At the time of the provisional removal, and I'll come back to this a little bit later, you can see now I have papillae that are standing proud. They're coming up more to a point. And in fact, when I get to it, you'll see there's little calls between the facial and palatal papilla. So it would be an ideal situation. So the interdental finish lines have to be positioned critically. They have to be moved lingual or palatal to the proposed interdental contact. A rule of thumb, I have no science behind this, but a rule of thumb, the wider the space, the more palatal I move the finish line. If I have a 2 millimeter space between the finish lines interdentally, I need to move my finish line 2 millimeters palatal to the ideal contact. 3 millimeter space, 3 millimeters palatal. So you're wrapping around the interproximals and you're doing 3/4 crown type preps to solve this, I'll say, with the appropriate contours. And these contours are represented here in the green lines. So I have a smooth transition from tooth to the ceramic to the contact. So when the patient flosses, they clean the ceramic, the margin, and the tooth at the same time. If I don't do that, if my finish line is left too close to the contact, the red wing is extending to close the space. Now there's going to be a concavity palatal to that. It's going to be a plaque trap, food trap, and it's going to be right on your margin, bad scenario. So it's not representing the most ideal form. So when I'll say develop these concepts for me, this goes back for probably 35, 40 years ago, solving real world problems, not only clinically, but technically. I had to figure out a way to avoid, I'll say, unnatural contours. Because my goal as a dental technician is to mimic reality, mimic the anatomic form. So that lateral wing is what we want to try to avoid. And so here, trying to show a smooth transition from tooth to ceramic. So using dental floss, it can be cleaned very easily. And you'll notice that there are little open interdental areas because I'm expecting the papilla to creep. So back to that one case that had the lateral wings of ceramic, the red line is showing you what was actually done. The green line is what I would propose to do. So try to think about this, ignore what you're seeing palatally. Again, I wasn't managing this case. The patient relates that the dentist was adjusting the occlusion and adjusted the palatal aspect. Try to avoid thinking about what you're seeing there. We're thinking about solving this interdental problem right now. So for me to solve that problem, to avoid, I'll say, if I had enamel left there, to avoid crowning the tooth, but now maybe I have to crown the tooth because of so much loss of tooth structure from the equilibration. I move my finish line wrapping around the tooth because it was a larger space, and therefore the green line now reaches the contact and it can be cleansed more ideally. So once again, tooth preparations before gingival retraction. I'm going to come back to that. I capture a photo of that many times so the dental technician can see that and the papilla are blunted. So now I fabricate my provisionals, 1.5 millimeter copyplast with a bisacryl, and then I shape the provisionals. So one of the keys for this outcome and predictability is contouring the provisionals. From Brasseler, I used my green shaping wheel. So it's a rubber wheel that I use to shape it. And I use a diamond trimming stone to create a very sharp edge, a very V shape, because I want a V-shaped interproximal area. I want to avoid a U-shaped area interproximally, because then the volume of space is too great. And I'm not going to get the influence on the soft tissue I want during provisionalization. So shaping this rubber wheel is essential. You could use a diamond disc, but that creates a line. You still need to come back with your green shaping rubber wheels and develop your convex form, finish it off with a high shine wheel. and that's the way you can achieve your best interproximal contours. So I try in the provisionals, I realign the margins, and these topics are covered in other online courses or in workshops. So the content I'm going through here right now, I'm discussing in a webinar, but SPEAR has thousands of hours of online content, and many of these topics are covered more specifically. And again, I'm trying to focus on a particular area, and that is manage the interdental soft tissue. So I spot etch and bond the provisionals in place. I didn't have all the photos of the same case. So here is the patient that we're currently treating. Provisionals are bonded on. I want to evaluate the soft tissue, I'll say in a minimum of 2 to 4 weeks, to see if I've had a positive influence on the soft tissue. So the bigger the problem, the longer you may wait, but a minimum of 2 to 4 weeks in provisionalization and assessment. That means the laboratory should not begin the final case until you know predictably you've managed the soft tissue clinically. So the provisionals are removed, the papilla are shaped, and you can see all of the papillas are standing tall or standing proud. Ideally, they should be V-shaped. Sometimes they are a little blunted, but that means I have more critical evaluation to do during my assessment. This is a patient I treated back in the early 80s, periodontal disease, and I prepped the teeth and provisionalized before the surgery. So there's going to be periodontal surgery to solve a biologic problem. And so you look at the provisionalization, and the provisionals were used to guide the healing of the soft tissue. So again, I've been practicing these concepts for a long time. Many of the cases we're not dealing with periodontal disease. I don't have to manage it as much as I did in this case, but the key is the convex restorative form is the key. Knowing where the contact length should be relative to bone, and that way I can predictably know if I'm going to form a papilla. So back to our patient, the master cast. So this, of course, is taken after gingival retraction. I use a one cord technique. I place the cord after tooth preparation, pull the cord before the impression, and then my master cast is made. And then many times, clinicians are thinking the technicians are going to solve all my problems, but they have no concept where the bone is, in particular relative to the stone cast. So the key is to communicate the distance in millimeters from the interproximal finish line to the anticipated papilla tip. So that's why I went through the earlier biology and finish line location and so forth, sulcus depth evaluation. Is the papilla going to creep or not? If I start out with a normal sulcus depth, probably is not going to change. If I start out with a shallow sulcus depth, excuse me, it may creep more incisally. So the only thing the technician knows for sure is the interproximal preparation finish line. So I need to give them a dimension of where to put the contact. And I'm using this as an example to explain the only time that I can truly represent soft tissue to the dental technician is if I'm doing an implant case and I have a custom impression post, and then we make our stone cast. So now I could say, I'd love to say it's an absolute or 100% replication of what's in the mouth. And so we don't do that in our normal crown and bridge work, veneers and crowns and so forth. So there's other ways we need to communicate. And that's why maybe at times we have optimum tissue health around single implant restorations. So again, the solid cast represents the preparations and the tissue. The tissue is maybe 90–95% accurate. So another example of before the stone cast is managed for shaping of the soft tissue. Then I use a barred Parker blade and scrape the stone away. So you can see it is a hard stone cast. It is not a soft tissue material like we do in implant dentistry. It's easier to manage this, but I'm scraping the cast specifically to create space for the restorative materials. So from a palatal view, you can see that now you can imagine your convex restorative form filling in that area to establish the contact, and then determining the finish line location to what the dentist told you where the contact is. Then you can maybe minimize or hopefully eliminate black triangles. So pre-shaped shaping procedures being accomplished. If I don't manage the cast correctly, the technicians will, I'll say, have a straight or negative emergence angle, and the ceramic will be covering the tip of the papilla, that blunted papilla, which is not the same as what you've managed with your provisionals. So this is an essential step. We expect every technician to know this, but the only way they know this is if you help them understand this, or they take, I'll say, clinically driven courses to understand these concepts. So this is post-shaping of the soft tissue. I do this in all the interdental areas, and then the restorations are fabricated. And you can see that I've left little tiny black triangles because I anticipate a 0.5 millimeter of papilla creep. So that means I expect on this cast to see black triangles. If you don't comprehend or clearly communicate effectively to the technician, most technicians will err on making a longer contact. It's going to be too far or too close, too far subgingival, too close to your margin, and you're going to be pinching off the papilla when you go to do the try-in. Okay, so this is all based on the anticipated movement of the soft tissue. By placing the finish lines interdentally as I described, I have a nice anatomic form, facial embrasures, as well as gingival embrasures. So communication with the laboratory, there's supplemental photos that can be really useful. Of course, a preoperative photo, provisionals at 2 to 4 weeks, and then a photo of the preparations, ideally before the retraction. And I'd like you to compare the prepped photo compared to the pre-op, right? And so this may, if there's 6 teeth, let's just say it takes you an hour to prep those 6 teeth, that's the transformation in the look of the soft tissue. And so that photo of the preparation with the blunted papillas, it's closer to what the technician is receiving on their stone cast, right? When they make their stone cast. So again, the photos might be useful. Of course, taking an impression and making a cast of your provisionals could be helpful. So in critical cases, you put more effort into the case to optimize your outcomes. So the patient's back for the try-in. So you evaluate the papillae, and you need to evaluate the sulcus depth before the provisionals are removed. So I want to see it a 2.5 millimeter sulcus now interdentally. And I connect my provisionals, they're not individual provisionals, so it does compromise hygiene a little bit. But when I contour my provisionals, if I err, I make that interdental contact too far incisal by maybe a 0.5 millimeter or an extreme 1 millimeter, but it's going to be a very narrow gap. The last thing I want to do is make that interdental contact in the provisionals too long and prevent the creeping of the papilla. Okay, so let's then think about the try-in. So remove the provisionals. I use a micro mosquito hemostat to remove the provisionals. You may have to cut them off with veneers. And we've already looked at this image a number of times earlier, looking at the papilla form. So it's managed nicely, and comparing it to, again, the before the retraction. So now during try-in, I quickly clean the teeth without getting too involved. I make sure there's no debris, no remaining, if I use unfilled resin, so I make sure there's no unfilled resin on the tooth. But I quickly try in each veneer to make sure it seats all the way. And therefore, I quickly check marginal fit. I then check 2 together, and I have to check the interdental contact to make sure it's not too tight. And I'm doing that by, again, checking marginal fit. Okay, so I'm looking at their fitting, their seating all the way. So what do I have to do next? I have to evaluate the tip of the papilla relative to the contact. And you'll notice here there is a tiny little space. And you can also notice that there is slight blanching occurring because the anatomic form I create on the veneer will be slightly different than that of the provisionals. So that slight blanching in that tiny little space, I'm confident that that papilla will fill in that space. The reason I have to do this efficiently, if you take off the provisionals and then leave the room to do a hygiene check and come back whatever time later, 15 minutes later, maybe you're seeing another patient, what happens to the soft tissue? It blunts, you don't have the support. So you can't evaluate this efficiently. So if I try it in and there's excessive blanching of the papilla, I have a problem. Either the contact is too far apical or there's excessive contour from the finish line. So that means it requires chair side recontouring of the veneers. This is highly stressful because I need to use reshaping. I would prefer to use reshaping rubber wheels, not diamond burrs, because then I have to come back and polish. But I have to do this pretty efficiently to make sure that I don't move the contact too far coronal. And if it takes too long, the tissue blunts and doesn't move quite as natural as it would. So this is one reason why I suggest putting a little effort in up front, communicate to the technician more information, and hopefully you don't have this problem. But this is the bad day. The bad day is when I try in the restorations and I have an open interdental space. So then you have to ask yourself the question, was the provisional over contour preventing the ideal papilliform and height? And so if the answer is yes, then that means we had the opportunity to predict if the papilla will creep incisally and fill in the space, right? So if I impinged upon the soft tissue and it's blunted, it will creep. If it is already at its maximum height or ideal situation, so now the papilliform is not present. Excuse me. If no, that means the ideal papilliform is present, then the contact of the veneers is too far incisal. What does that mean? That means you have to add ceramic to improve the restoration contour to establish the right contact at the right level, and that would be at the height of the papilla. So the reason I say this is a bad day, most clinicians don't have ceramic in their office and a firing furnace and taking the time to do that. So that means trying to get provisionals back in the mouth. So that means many times with veneers, you're fabricating new veneer provisionals. So you don't want to err on having the interdental contact too far incisal and having a black triangle. And we've already have the optimum papilla form. So this is where we started with our patient. He had diastemas, diverging roots to the teeth, so bigger problems than maybe you realize clinically. And then these are the final restorations approximately a year after the insertion. Patient had his staff as a dentist photograph the case and send them to me, so we have optimal soft tissue form. So I would like to thank everyone for their attention. I tried to leave a little bit of time for some questions. So I'm going to see if we have any questions rolling in. So how do you know if you have over-contoured the provisional with a space? I tried to touch on that in those last images, right? So if I've over-contoured the provisionals, and that means it's prevented the papilla from creeping incisally, I have a shallower sulcus depth. So I try and evaluate that before I remove my provisionals. So if I figured out, let's say it's 2 millimeters and I expect it to be 2.5, or let's say it's 1.5 and I expected the papilla to be 2.5 height, so or in sulcus depth. So therefore I expect the changes to occur. So it's evaluation before the provisionals are removed. Once I remove them, I can try and double check it, but it's not quite as good. There are no other questions. So with that, we scheduled 45 minutes to an hour. We're just over 50 minutes. So my concluding thoughts. So this particular topic, looking at interdental spaces and using veneer restorations to close these off. We looked at biology. We looked at managing the interdental areas with provisionals. We expect our technicians to address many of these issues, but we don't give them enough information most of the time. So here we want to give enough information that we can have predictable outcomes without any significant adjustments or remakes at the time of trying. So this was a webinar. We do these live. We have, as I mentioned earlier, many hours, thousands of hours of online content similar to this topic and many others. We try and cover as many topics as we possibly can. So please visit Spear online if you're interested in other content. If you're interested in hands-on workshops, because I do a lot of, in fact, this particular case I use in a workshop on anterior restorative dentistry. And so we're managing these exercises with provisionalizations and so forth. So we have lots of information here at Spear. I look forward to seeing you either online in another webinar or live on our campus. So thank you for your attention. Hope everyone has a great day and a safe day. Take care.